Thank you. My name's Louise Fuller and I'm a dermatology registrar at Basildon Hospital, and I'm presenting on behalf of Dr. Jasani, Dr. Suchak and Dr. Khorshid. We looked at whether store and forward teledermatology would be beneficial in our hospital as part of an integrated dermatology service to help both optimise patient care and streamline service. We currently don't have teledermatology at our hospital. So for those of you who don't know, Basildon is situated in the southeast of England, about 32 miles east of central London. 70% of the district is rural, with large areas of open farmland and scattered rural development. By 2035, the proportion of people aged 65 and over in Basildon will have increased by 23% to just over 46,000 people. Basildon was started as a new town in the late 1940s, and we now have our own Basildon version of the Hollywood sign in America, which sits at 5 foot tall. It's a ninth the size of the original. So we do receive referrals from as far north as Colchester, from Romford to Southend, and the occasional referral from Kent. So Basildon Hospital itself serves 405,000 people across southeast England. It became one of the first foundation trusts in 2004, and currently we provide dermatology services to the whole of South Essex, and our catchment area is about 1 million people. Our main site for dermatology is Basildon, but we also have clinics in Southend and Orsett, and we work closely with the doctors at Broomfield Hospital in Chelmsford with joint clinico-pathological meetings. This table shows the skin cancer referrals to Basildon Hospital from 2012 to 2016. The number of referrals has increased from 2,401 in 2012 to 4,006 patients this year, not including data from the final 3 months of the year. We now average 445 referrals per month to be seen in our clinic. This graph shows our 2-week wait skin cancer referrals month by month since 2012. The dark blue line that runs along the top of the graph highlights the increase in referrals seen this year compared to the previous 4 years, with the highest number of referrals seen in July and August. So our current skin cancer service comprises of our See and Treat 2-week wait skin cancer clinic, where the majority of our referrals are seen, and then the other 2-week wait referrals are scattered within our general clinics. Patients are seen on a Thursday morning in a pooled clinic comprising of 7 doctors and on average 4 specialist nurses. Patients are reviewed in clinic with a thorough history and examination, and the photographs or biopsies are taken on the day. If needed, the patient is discussed in a local skin cancer MDT, and the patient is brought back to clinic 3 weeks later for the results. So we started the service just over a year ago, and although it's working well, with the increased number of referrals to dermatology year on year, and particularly the increase in referrals over the summer, our service is stretched, like I'm sure many of yours are too. Patients get seen and treated on the day, and the waiting clinic is around 3 to 4 hours. So we asked the question, can teledermatology help? Would us offering a teledermatology service to our local area improve both patient experience and outcome, but also take some pressure off our overstretched service? So in order to do this, we took consecutive patients who attended our 2-week wait cancer clinic, and they had a clinical consultation and had a photograph taken in clinic. The photographs were taken by a medical photography department with no demoscopic images taken. These photographs, along with the GP letter, were reviewed by 2 consultant dermatologists independently. One consultant had 19 years experience, and the second had 3 years and 3 months consultant experience. A decision was then made regarding the diagnosis and the most appropriate action for the patient. This was compared to the outcome from the face-to-face clinical consultation. In particular, it was noted whether there was concordance with the GP for suitability for referral to the 2-week wait skin cancer clinic, whether any malignancies were missed from doing teledermatology, and how many clinical episodes could have been avoided. So 95 patient referral letters and photographs were analysed by the 2 consultants, independent of them being seen in clinic. As one consultant was unable to review a patient's image and GP letter, 1 patient was excluded from the analysis. Therefore, there were 94 patients in total analysed. The consultants made their decision as to the outcome of the clinical episode from both the photograph and the GP letter. And the decision that they made was whether or not they agreed with the GP referral, and it was marked for 2-week wait, whether the referral should be downgraded to routine, or whether a advice letter could be sent to the GP and the patient didn't have to attend for an appointment. The surgical diagnosis from the biopsy was also noted. A comparison was then made between the usual see and treat 2-week wait clinic pathway and our teledermatology pathway to try and decide if one was better for the other for patient care and hospital services. So all data was analysed using pivot tables in Excel. So 34% of the time, the consultants agreed with the GP decision for a 2-week wait referral. This is a lower percentage than previous pilot studies that have been performed. Battalion 9 at Hertfordshire, via a 6-month referrals via the 2-week wait pathway, collated 110 digital referrals and concluded that 52% of their referrals were inappropriate compared with our 66%. A study at the Royal Bournemouth and Christchurch hospitals presented at the BAD this year had an 81% concordance with the GP decision for 2-week wait referral, using an iPhone 5S to triage the referrals and streamline service. We then looked at each consultant individually to analyse how they graded the referrals. Interestingly, the consultant with more experience graded more referrals as needing a 2-week wait and gave less advice letters to the GP. In total, there was a 75% concordance rate between our two consultants and how to manage the referral. 11% of the time there was discordance regarding appropriateness for the 2-week wait referral. There were no malignancies missed through our teledermatology in this study. One patient was felt to have a seborrheic keratosis by one consultant, however their biopsy showed an actinic keratosis. This can be a tricky diagnosis to make clinically, regardless of teledermatology, with both lesions showing similar features. But as it's felt that less than 1 in 1,000 actinic keratosis undergo malignant transformation, the clinical harm from this is low. Interestingly, from all the referrals seen in clinic, 68% of patients underwent a biopsy, of which 17% showed an appropriate 2-week wait malignancy, which we deemed as being a superficial spreading malignant melanoma, squamous cell carcinoma, lymphoma, or Merkel cell carcinoma in this cohort. 26% of patients would have avoided at least one clinic appointment in this sample, with their GP receiving an advice letter. This could have potentially reduced days off from work for patients, help alleviate some of the patient load in clinic, both in time of space, time and cost. And all the photos that I've shown you in this study, on this presentation, have been from the study itself. So our teledermatology study indicates that it may be a useful adjunct to current service provision in our area. However, compared to other studies of a similar nature, our GP concordance was lower. There could be many reasons for this, but we feel the biggest contributing factor is that our photographs were taken by medical photographers and therefore were of excellent quality. The lesions were marked prior to the photograph being taken, and then professional photographers took them in our medical photography department. This may not be representative if we were to roll out the teledermatology service to the local area without adequate training. So in conclusion, we feel that in addition to our current patient pathways, we could benefit from an intermediate teledermatology service where lesions can be appropriately triaged to clinic or education and advice given to the GP, helping to both improve patient care and service provision in our area. Thank you.